You for joining today. My name is Omar Latif. I'm the president and CEO of Rush University Medical Center. We are adjusting our technology. We're about to show you a slide display and get started with our program for the day. Today, we're really going to talk about Rush and Rush's response to COVID 19. The title of today's presentation is Built for This: Rush's Response to COVID 19. We're very thrilled that you were able to join us. And so, to keep us on schedule, I'll just jump right in and allow us an ample amount of time to answer more questions as they certainly come in. So, these are the panelists you'll be seeing today. I'm on the left. Dr. Paul Casey is the acting chief medical officer right next to me. He's the associate professor of emergency medicine and the vice chairman of operations in the emergency department. He's also been integral in managing our COVID 19 response and our top doctor in the institution. Dr. Angelique Richards is a chief nursing executive in the Rush system, but she's also really the senior vice president of hospital operations and managing the intimate details of how we're responding across the organization. She's the associate dean for practice at Rush University College of Nursing as well. Dr. Michael Lin is an associate professor of medicine and infectious disease, a nationally known hospital epidemiologist whose work has been published both nationally and internationally in the past, and has done a remarkable job in guiding us through this pandemic so far. Really, we're just going to start by thanking you for the work that you're doing, the support that you've had of us, and your interest in our organization. I'm going to start out with talking a little bit about our situation at the national, state, and local level, our response, the people who are working. We'll talk about testing, and we'll talk about how getting back to daily life and what we think about that and where that's going to be. Really, the first thing I'd like to say in our thank you is that we've had two anonymous donors who've established a 1 million COVID 19 matching gift challenge. And the terms of this gift are very simple. We will match the donation to our COVID 19 response efforts up to $1 million. It's an opportunity for our donors to double their impact. Really, since this has started, we have had an overflow of well meaning people from all over the United States of America send us precious resources of their own, money to help us keep our operations running from all parts of this country. And we've actually even received some money from international donors. Some of it's small, some of it's coming in $5 and $10 amounts, but it tells you about the spirit of people and their willingness to get involved and fight. And this is what we're fighting. This is a map from Johns Hopkins University that shows, it's called a heat map, and it shows you the cases all over the world. And what you should take from this map, if you saw what this map looked like 8 weeks ago, the United States of America had one or two little red dots in it. And Asia was lit up red like Europe and North America are. You see now Asia, the amount of red start to decrease, and in Europe and North America just take over. And this shows the rapidity of the spread of the virus, of the coronavirus virus or COVID 19. In the United States, there's now over 1 million cases, and the number of deaths are staggeringly high, already close to 70,000. And the predictive models show those numbers as we reopen, even climbing to the well over 100,000 in the future. The reality is, this is a virus as it spreads. Why some of this graph will change dramatically is it's limited in testing. And when we talk about testing, you can only become a point on a graph if you get a positive test. There are entire countries that are limited in their ability to test and are hardly testing. So those countries would then look not red despite rapid spread. So the reason we would say that this is a global pandemic, this is a disease that is spreading all over the world and no region is spared. And the state of Illinois tells its own story. As you know, Illinois was impacted after first the state of Washington and later the state of New York at a large level. Illinois had the benefit of learning from the response of those states and learning from history, and was a little more aggressive in a stay in shelter order, which largely led to slower increase in numbers in the state of Illinois as there were in New York City, as an example. We've had 63,000 positive cases of COVID 19 in Illinois and close to 3,000 deaths. We performed over 300,000 tests. At Rush University alone, and we've had 15,327 people tested and 4,000 confirmed cases. We've had right now and today as we speak, there's 160 COVID positive patients admitted to our hospital. Of those, 89 are in the ICU. And when you think about the staggering number that is, these are patients in our normal operations as a hospital. We have 24 ICU beds that take care of medical patients with pneumonia. We have 89 ICU COVID positive patients, which means we physically transformed our hospital into a giant ICU in large part to take care of what we believed was going to be an onslaught. Our preparation was for the worst case scenario. And so when you walk in the hospital, you won't see the carnage that you'll see in other hospitals in the country who perhaps were not as prepared for the rapidity and severity of illness of these patients. You will see a peaceful, calm environment, but one taking care of the highest number of ventilated patients of COVID, patients on a ventilator that have COVID in the state of Illinois. That's what's at Rush University Medical Center right now. In fact, many of these patients are not only on ventilators, but they're flipped upside down. And that is an act that is heroic. It's done by around 4 or 5 people inside the room that actually take a patient and turn them over to help them breathe. And we have 12 patients that are on a heart-lung machine, an actual machine. When the ventilator can't do enough to get oxygen in your body, we're taking all the blood out of a person's body, running it through a machine and funneling oxygen into it and then pumping that back in. And that has been a life-saving approach called ECMO that we're routinely employing right now. As I speak, we have 12 patients on that right now. And just so you understand collectively what type of resources they have, we can typically do 10 at one time. So while our cap is 10, we have 12 on it today. We have 89% of our patients were discharged, which gives us a mortality of 11%. That mortality may look high to many of you who are listening. The reality is when you adjust that for the patients that we have, it is phenomenal. There are hospitals that are showing a 75% mortality for their patients that are on a ventilator, and those are some of the more recent publications. The only patients we're accepting in as transfers at Rush are the sickest patients in the hospitals in the area. So if they're on a ventilator and getting worse, those are the patients we're taking. And to boast an 11% mortality is a phenomenal number. If you look across the state, you see pretty scary numbers. So the graph to the right on your screen right now, just look at how tall the line is. And that line tells you the number of new cases each day in the state. What we want is after this goes up to level off and then go down. That's what everybody talks about in our terms of new cases. But yet in Illinois, our number still seems to pop up and down, which means we still have a lot of spread in our state. What we do have an improvement is a graph on the right, which shows doubling time. Doubling time is an important number. That shows how many days it takes to double the number of cases in an area. So what was scary was when this was spreading rapidly initially in the state of Illinois, the doubling time was like a day. In a single day, we were doubling the number of cases from one day to another. All the stay in shelter orders, all of these mitigation efforts result in increasing that doubling time. So what is good is for the most part, we were improving, but then you see around the 17th, 18th, and 19th tapering off, which meant that there must have been a give in the system because all of a sudden we had more cases than we were hoping to get. It wasn't continuously getting longer. We would love the doubling time to be over 100 days, 200 days, 300 days. And there are countries that had been able to do that. What we do here in the future now more than ever is we recognize that the world of the next 2 weeks, 2 months, 2 years is going to be very different than we had ever predicted before. And the world in healthcare is not immune to those changes. It seems a bit tragic to look at this way, but healthcare systems and hospitals have to prepare for not only the financial challenges the rest of the economy has to prepare for, but has to somehow predict what's going to happen in an unpredictable time. So to do this, there's 3 limitations that every healthcare system has: the number of beds, the number of staff, people who can work at those beds, and the amount of supplies they have. We've developed calculators, and we can look and say, this is how many people are getting the disease, so this is how much we will need of each one of those precious resources. And we're using those to predict the future. And while you've seen all over the news many different models, it is the trend of the models that's most important. So we're estimating how many ICU beds do we need? How many masks do we need? How many pairs of gloves do we need? Every day, this is constantly changing as we input the numbers from the state. And that's done largely to inform our future. You're looking at this next graph, and it's a scary picture. I'll just talk about the impact of COVID. When you talk about the impact of COVID, You look at the opportunities here on one side. You see research. What is happening now in the United States of America is that every hospital functions in isolation. Unless they're part of a system, the system functions in isolation. When there's an epidemic or a pandemic, it's so important to share information. And we're seeing hospitals for the first time break down those silos to work together. We've seen a massive growth in virtual health and telehealth. In other words, just being able to sit in your kitchen and seeing your doctor and going over your health care. We've seen federal coronavirus or COVID funding, which is starting to trickle in. Unfortunately, it's not coming in at the rate hospitals are losing money and revenue. And that's why you'll see some of the pictures to the right. As you look to the right, this represents the single biggest challenge. This challenge is the economic impact on healthcare. And this feels really wrong, right? And the reason this feels wrong is because in reality, when healthcare are the heroes that are fighting an epidemic, it seems odd to say 11 to 1,800 hospitals in this country are going to go out of business because of this. The challenges each hospital has is how many beds they have. What kind of supplies do they have? And how do they manage fear and get enough people to work? We talked about bed supply and staffing, and so we're predicting how to keep buying those. The financial pressures that this disease brings are unprecedented in healthcare. The engine that drives hospitals in America are things like surgery, and we can't do those while we're taking care of COVID-positive patients. The amount of resources that it takes to take care of a COVID-positive patient is effectively almost more than what it takes to operate. So not only are we not doing the things that generate revenue in healthcare in America, we're providing a phenomenal amount of care to things that are not reimbursing the healthcare system. So this is why a prominent hospital in a really good area of Detroit actually had to eliminate 450 positions, furlough 2,500 people, and actually close one of their hospitals. This is why every day you're hearing more and more about across-the-board cuts. I think nothing was more prominent when the Mayo Clinic came out and predicted an over $500 million loss in the future and then did across-the-board cuts. I can tell you that while you're hearing all this, these hospitals are not rush. We believe that we're in a position to make it through this pandemic from years of planning, not for a pandemic, but of a conservative approach. And now we're going to try to leverage every part of our operations to safeguard the 13,000 employees that work in this organization. At the very least, we are going to ensure that every employee that works on the front line of this organization, everybody in jobs that are financially stressed, are supported by this institution. The results of this have been pretty profound. We've never had the international footprint and national footprint than we've had in the last 2 months. In fact, Rush University is inundated on an almost daily basis by people wanting to do stories about the work that's done here. Some of it is around ECMO. Some of it is around what is it just like to take care of these patients. Some of it is around proning. We're part of over 40 trials, and the work that's being done and how the creation of our hospital really prepared this organization for this has been phenomenal. This is just a sort of a small image of some of the press that's happening, but I could present a slide like this for every day. You see social media. This is an interesting slide. Rush University Medical Center for a day last month trended as the most read about hospital in the United States of America. And that's in part because of all this work that we've shared with you, and in part because it's true that we do feel like we were built for this. So when we say Rush University was built for this, here's what we mean. There's a building and there's a culture. The building that was put up, which is the tower, is uniquely built to allow us to change air pressure, to increase surge, to get extra beds. We had extra supplies. We were proactive in obtaining even more supplies. But the biggest limitation that any healthcare organization is going to have comes in the form of people. If people aren't engaged and people are not part of that organization and don't share the same mentality, you could have the most amazing building in the world, but not be able to offer care. What's at Rush University Medical Center is a mentality that says, I can. It is a mentality that says we will not turn away from patients that are coming in. Hospitals across this country shut their doors to transfers. We not only kept ours open, we told hospitals we're only going to take your sickest patient. We took the weight of this city out of pride, and it was the employees of this organization that did this every day and that are doing this every day now. This video highlights a program called ECMO, which is the heart-lung bypass machine. And this is a picture of a patient that was going to die without it. And not every hospital can offer it. In fact, probably less than 5% of hospitals in America could even do this, but we're doing it in an unprecedented amount. So I'll encourage you to watch this video. We have been successful in treating patients with this modality and have phenomenal outcomes in doing it. This is a patient that will walk you through his journey of coming to the hospital, and you'll see what happened to him and him leave. And it'll take only 4 minutes, but I strongly encourage you to watch it.
I got a fever for 1 week without stopping, and then my breath started getting short. I cannot breathe. My lungs, it wasn't working.
Rush offers a series of heroic treatments that are just not employed routinely in the care of patients. One of those is ECMO. So we're taking patients that are on the brink of death, putting them on ECMO, and then later watching them sing songs or walk in the hospital.
ECMO, ECMO, stands for extracorporeal membrane oxygenation. It's basically a simplified heart-lung machine similar to what they use in the operating room for heart surgeries.
We're able to provide a machine that takes over the work of the heart and the lung and is able to essentially save a person from dying. And we're able to work on the patient and able to get them through a very critically ill phase. Our success rate is based on national average. We are at 20% above the national average in saving patients with VV ECMO, which is a specialized form of ECMO for supporting the lungs. Treating patients now with COVID pneumonia and COVID lung problems, that expertise is being brought into play.
My family told me that when they told me that I need a machine, and they needed somebody to say yes to connect it, they was scared. It was the only option I had. So they told me they had to do whatever they can to help me out. Everything, the machine was everything. Yeah, without the machine, I don't know what happened.
Our physical therapists, occupational therapists, and speech therapy teams all see them then to work on eating, their self-care, getting up out of the bed, and when they're ready, even walking in the halls.
And that allows us to have long-term results that are fantastic, because the recovery process is not just the human body, it's the human spirit and the soul.
I believe everything is mental. You know, even if you know you are connected to machine, you have to love the machine, because it's the one that gives you another chance to live.
For our first ECMO patient that was COVID positive, that was in severe respiratory distress, did well with our ECMO support, and we were able to take the breathing tube out, where he was able to rehab and eat as well, and we were able to finally get the ECMO machine off.
So thanks to the machine, I'm right here. I'm ready to go home today, and my family is waiting for me.
Dr. Tubachnik, part of the ECMO team.
Thank you.
You look great. I just want to check this site.
Yeah,
This looks good. Okay,
You're ready.
good. You have questions?
Thank you.
Oh,
Thank you, Dad. God bless you.
no.
You guys are the angels, so I really appreciate what you guys, all of you guys did for me.
It's our pleasure. You go out there, you live a full life for us, okay?
It's a completely new life.
Absolutely. Your lungs look perfect on x-ray. We'll keep an eye on you with the lung doctors, okay?
Yeah.
Okay.
This is Dr. Camino.
Hi.
She's the lung doctor who called us. She's the one
Hi.
who called us that said you needed ECMO.
I can't believe I'm meeting you for the first time, really.
Look at me.
Oh my God.
that on,
Can I shake your hand?
No, I mean,
Oh my
Thank you.
God.
thank you. Really appreciate all of you guys.
Oh my
Thank
God,
you.
I can't believe it. I cannot believe this. You are the same person.
I would attribute the successes that we have with these patients to the commitment and passion of our team.
The ability to be able to intervene and save a human life, and to be able to interact with that patient after they have recovered from this, that moment when you have a patient who reaches out to you and says, thank you, that is my proudest moment.
There's technology, but there's the emotion that goes into caring for these patients. There's a philosophy of how we're going to take care of each one of these patients and a desire to push the envelope. It's our culture and who we are, and there's no better way to see that than in this program. Turn the presentation over to Dr. Paul Casey to talk more about what we've actually done here.
Thanks, Dr. Latif, and good afternoon, everyone. Thanks for taking the time to join us today. So Dr. Richard and I are going to cover some of the preparedness changes we made, some of the reactions from staff, as well as some of our future plans around this. And I think back to late February when we pulled together under Dr. Latif's leadership and looked at our preparation. And I remember Dr. Latif at that point saying, we're never going to look back and say we were too prepared for this a year from now. And wouldn't it be great if we did look back and say we over-prepared? So that's really been our philosophy throughout this, is that we need to be over-prepared in order to be able to take care of the communities we serve. So we also prepared our community to undertake a large amount of change. We were truly undergoing what would have taken years in a matter of weeks in order to be prepared for this effort. And really, there were 4 different buckets into which this effort fell. One was our physical capacity. And Dr. Latif touched on the fact that thanks largely to the philanthropy of donors like you, or probably donors that are listening today, we were able to build a tower that had extraordinary capabilities that really set us off well from the start. But we also had an extraordinary amount of space that we were able to increase our bed footprint in the ICUs by 72% to take care of the sickest patients in the city. So we went from 111 beds to 193 beds that are nearly full today with critically ill patients. We also stood up the ability on our medical surgical floors. We increased from 358 beds to the ability to go to 547 beds. So really few hospitals have that capability to really surge like that, and we wanted to make sure that we could do that. Now, secondarily is the staffing. We had staffing models built around providers, nursing, respiratory therapists, as those critical support services to really not just be able to take care of the patients that we're presenting, but also think about how COVID might impact our staff. Paramount to all of our planning has been the preparation and the protection of our staff, because that truly is our most critical asset here at Rush. As Dr. Latif said, it was certainly a concern early on how staff would respond to being asked to work in areas they didn't traditionally work. And in an extraordinarily Rush-like manner, we've had people not just adapting incredibly well to new areas and working in teams they've never quite worked with, their instructors they've never quite worked, but even those that were not set to work were asking when they could become part of the surge planning, when they could start taking care of COVID patients. So just an extraordinary effort from everyone throughout the hospital. Next was our equipment and supplies. And really, that's where we relied a lot on the modeling that Dr. Latif pointed out. We also work closely with the city, both the Chicago Department of Public Health and at the state level, the Illinois Department of Public Health reached out to us to try to help with some of the modeling around ventilators, beds, capacity constraints within the city. And that work is actually ongoing. We have daily phone calls to really talk about how we align these resources throughout our communities to really be able to best serve our city. And that's also an extension of our work that we did at the McCormick Center to really help them stand up an electronic medical record in a record amount of time. We also looked at being able to optimize our in-house capacity. We early on made the decision to reduce our elective office visits, our elective surgeries, in order to be able to take care of COVID patients very intentionally. We stood up implementation of alternative care models, including permanent staffing, in which we had one critical care doctor overseeing other faculty members from different specialties that were able to then help in the care of all of our critically ill patients on a given floor. Similarly, on the nursing side, we use some unique new care models, and we've really benefited and learned from those in how we move forward. And then we'll talk a little bit about our virtual care. We had an extraordinary capability to stand up virtual care, and I'll tell you in a minute about how well we were able to use that existing platform to really be able to continue to provide patient care for patients that need their routine preventative care. Just before moving on from this slide, I think it's worth reiterating the point that Dr. Latif made that, you know, all of this effort was essentially to allow us to fulfill our underlying mission of taking care of the sickest patients in the communities we serve. So we had proactively reached out to our safety net hospitals to say, we're here to help. We've taken in over 100 critically ill COVID patients throughout this pandemic that otherwise very well may not have survived in some of the hospitals from which they came. So we're proud of that, and that's really work that will, I think, boost our reputation as we move forward. So we also were able to bring some new services to our community. And as I mentioned, staff was paramount to how we approached the pandemic. So we wanted to be able to prioritize in-house testing for not just for our patients, but also for employees and first responders throughout the city. That really allowed us to take care of the frontline healthcare providers that were going to be essential for the ongoing care of COVID patients. We also partnered again closely with the city to be able to go out and test various nursing homes in the area where we knew there was a higher risk in those congregate settings for more COVID patients and that they could quickly spiral out of control into clusters. So our team, with the leadership of David Ansel and Angela Moss, reached out to nursing homes and actually went out proactively and tested patients, which has been really transformative. We stood up a COVID walk-in clinic early on in this pandemic to be able to take patients in. I remember the early days when we were trying to figure out how to operationally get 10 or 12 patients through in a day. We are now talking about how we're getting, between our walk-in and the drive-through, how we're getting about 400 patients through a day. So just an incredible effort. And you can see there on the right-hand side, the drive-through tent, which we actually set up for those of you that have been to campus, just under the L tracks in the alley adjacent to our professional building, to really allow a little bit of confidentiality to the visits, but also an operationally sound place to be able to do this close to our walk-in clinic. On the picture on the bottom with the blue tents, that's our forward triage in the ambulance bay. So this is really a new model that we employed in emergency medicine, so that when a patient walked in and was identified as having potential and influenza-like illness, we were able to separate them right from the start toward our ambulance bay, where they received both point-of-care testing and further assessment. So many patients were able to be discharged directly and continue today to be directly discharged from the ambulance bay without ever intermixing with other people seeking care in the emergency department. Those that are sick are brought into a negative pressure pod that's dedicated for COVID patients. So again, we want to make sure that everyone feels safe within the setting. We also stood up, as I mentioned, a number of new full-service ICUs. So it really took an extraordinary team in critical care medicine, supported by all of the departments, to expand our critical care footprint throughout the hospital and be able to really safely, and not just safely, I would say better than many places, be able to provide this critical care, and our outcomes truly speak to that. And then finally, as I mentioned, we were able to convert a number of clinic visits into a virtual care. And we had the advantage of our existing MyRush mobile app that we could use and the integration with on-demand visits that we had already stood up. So we were in pretty short order as of today. We're seeing about 80% of our ambulatory patients through this virtual care platform, which is just extraordinary. And it's something that a lot of other places have really struggled to be able to pick up at this point. And I think truly this is something we want to be able to continue to offer, this convenience and value to our patients moving forward, which we will. So with that, I'll turn it over to Dr. Richard to talk a little more about the surge prep.
Thanks, Dr. Casey. Good morning, and on behalf of the 13,000 family members here at Rush, I'd like to extend my heartfelt thank you to each of you for your continuous support of our efforts. I'm going to share with you a little bit about the how. So as you can see in this slide, these are our recovery areas in which we converted that space to be able to increase by 72% critical care capacity, and almost doubling for our medical surgical beds. We also utilized our Brennan Pavilion area to be able to safely care for our non-COVID patients that were coming into our organization via the emergency department, as well as our COVID patients. And I think that's an important point. We dedicated units and departments as COVID and non-COVID areas, and have cared for both populations throughout this pandemic. Next slide, please. And these are the faces of those 13,000 heroes of this pandemic. I want you to know that the spirit is very, very strong here. The resiliency, the commitment to patience and excellence has never changed. The commitment to our community, it is inspiring and truly heroic. And I'd like to spend a little time talking about the impact that this pandemic has had on our employees and how we've responded. So it has been a challenge for our patients and as well as for our employees. This has been a novel virus and something that none of us have had to deal with certainly in our lifetime. And so our employees have had fears, for themselves as well as for their families. We have had as this virus spread to the community, we saw exposures, which resulted in staff furloughs. There have been concerns by our employees about, is this a safe environment that I'm coming into? Will we have enough PPE? All of us have certainly witnessed some of the challenges that other states have experienced, and of course that incited fears amongst our own employees. Concern about transportation to and from work and exposure from that perspective. There were many questions about our PPE equipment, and much of that had to do with as we continue to learn about this virus, we made many changes based on the CDC guidelines, and many times that caused confusion for our staff and incited more questions. There were community perceptions, and while overwhelmingly they have been positive, many of our staff experienced some of the unkind perceptions of the community. So harassment for staff who were taking public transportation or shopping at a store and while wearing their uniform. Or requiring car services, and being refused because they were working in healthcare. There have been significant financial impacts to healthcare organizations across the country, and we are certainly not an exception. There have been responses to this in the form of hazard pay pressures, and agencies and unions who have capitalized on this opportunity. And so I want to spend a little time responding to what our response to our staff has been. They are truly our greatest asset here at Rush, and our response was swift and continues. We first and foremost wanted to make sure that they had an opportunity on a regular basis to ask questions and have them answered real time. We conducted weekly town halls for the entire organization, and then many of us spent time at the unit and department levels conducting town halls to make sure that questions and ideas were gathered. We stood up a Rush daycare center for our employees, for their children. This happened very quickly after the schools needed to close. We provided housing accommodations and transport assistance to help and to support our staff. We opened up our parking structures free of charge from the very beginning. We purchased 5,000 scrubs and provided laundering of those scrubs, not because this was a requirement of the CDC, but to provide comfort and peace of mind to our staff, those who were taking care of our COVID population, so that they would not have to wear their hospital uniforms home and launder them at home. PPE accommodations were made pretty much around the clock. We partnered on a daily basis with the mayor's office to address community perceptions and needs and responded in kind. We created a Rush Heroes campaign to acknowledge and recognize the many, many heroes in many different roles within the organization. As I said before, our leaders rounded 7 days a week and around the clock to ensure that our employees felt heard and safe and their questions were answered. And then we too responded with a small token of our appreciation while doing this during a significant impact, as I said, financially to our hospital as well as hospitals across the country by providing them with a small token of our appreciation and in some cases crisis pay for our patient-facing positions. Next slide, please. I have to tell you the most rewarding part of this whole experience has really been the community support and your support. It has just been overwhelming, the acts of kindness. And as you can see in this slide, we had beautiful messages that our Child Life Department painted on sidewalks and in our garages so that all of our employees in coming to work every day would be uplifted and inspired. We had a trustee who donated over 600 lilies for Easter. As you can see, our former mayor dropping off food. There are hundreds and hundreds of food donations that have been made, and it has been such a delight to be able to distribute those almost on a daily basis to all of our staff and all of our departments as a sign of support from our community. And then up in the top right-hand corner are some signs that our lads, school kids have made that we have posted throughout the organization, again, to uplift these heroes on the front line. And at this point, I think I'm going to turn it over to Dr. Lin.
Thanks, Dr. Richards. So again, I'm Mike Lin from Infectious Disease, and I have the pleasure in telling you a bit about our research for COVID-19. Again, this is so much due to your generous funding support for our prior research and our expertise. Rush really has expertise in clinical trials, especially in viral treatments such as HIV and healthcare worker safety with our CDC funding through the Epicenters work. And so it's really been a heroic effort to pivot a lot of our research expertise to fighting a common cause, the COVID-19. This slide just gives you a snapshot of some of the trials that are being done and other studies at Rush. Just to highlight a few, the Rush COVID-19 biorepository is really an unprecedented type of resource that Rush is building, where we are taking information from our patients and also collecting samples such as blood samples and other test samples with patient permission to be able to study outcomes of COVID-19. What are the predictors of severe disease? What are the immunologic responses and biomarkers that may help us in the future take care of patients in a better way? The next couple of bullet points talk about potential treatment modalities for COVID-19, such as convalescent plasma, and also a drug called remdesivir, which is an antiviral that's effective against COVID-19, at least in laboratory settings. And so you've probably seen some information from the news about early trials showing some success for remdesivir. There's still so much to be learned about this drug and others, whether it is effective for one, but when to use it and for which patients. And so a lot more is needed. I think the science that we're doing here is something that is contributing to our ability as a society, as a nation, to be able to lead us back to normalcy. And so the science that you're seeing here is all about trying to figure out how the virus spreads, how we're able to best treat it, how we're able to treat it successfully and safely so that healthcare workers are not contracting COVID-19 during their efforts to provide care. And what happens to patients after they recover? How do we lead them back to normal lives? And so this is really just a snapshot of what we're doing here. And again, to your support is so important to helping us achieve these ends. On the next slide, I just want to give you a snapshot about antibody testing. So you've read about this probably as well, that antibody tests are a potential way for us to be able to figure out if somebody's had prior COVID-19. It implies that they may be protected in the future, although we don't really know for sure, and this is part of the science that's being worked out. Some of the tests that are out there, frankly, are not accurate. So some of the point-of-care tests that look like pregnancy tests that are done at the bedside are not very accurate. The lab-based testing, which is what we offer here at Rush, does appear to be highly accurate, at least for negative tests. If it's negative, you're unlikely to have had COVID-19. And if you're positive, we're still trying to get better data around that. There is some potential for cross-reactivity of this laboratory-based test to other coronaviruses that are normally circulating. We actually have high hopes for the test that we're offering. And the test that we're offering is geared towards, at this juncture, staff and students. So we are the first healthcare system in Chicago to offer this type of test to all our staff and students. When we offered this test, there was a lot of interest, and 1,900 plus staff and students signed up within 2 hours, and we're still seeing 300 to 500 a day signing up. We hope that this activity will give our employees some peace of mind to try to understand where they are at in terms of their exposure to COVID-19. And it also helps us to understand some really important scientific questions, such as, if you're positive, what does that mean? Do the positive antibodies confer immunity? So we are using answers to these questions to get to our Get Back to Work strategy, which will be discussed on the next slide. We are leading the science by studying these questions. We have put out a scientific study that's questionnaire-based that employees are filling out, and I'm really grateful to our employees and students. So many of them have signed up, and that information will help us figure out what do past exposures mean to this antibody result, and what does the antibody result mean for their future. So a lot of interest. We're really excited to be able to be leading the way in this effort. The next slide, I'll hand it back out to Dr. Casey and Dr. Richard.
So this is actually exciting and fun part, I would say, of what we've been doing in the last couple of weeks, which has been reversing the surge. And as I said earlier, we have never stopped caring for our non-COVID patients. And as we start to see them to come back into the organization and need our services, as well as to respond to the governor's recent suspension of the elective surgery hold effective on May 11th. We have over 30 plans in the hospital operations area alone to ready our organization again for our not only to care for our COVID patients, but to also care for our non-COVID patients. In some cases, that includes reversing parts of the surge plan, so returning, for example, some of the recovery areas back to the surgical platform in preparation for the surgeries that we will be doing. And also looking at this in a two-phase fashion, looking at triggers that will help us to know when it is time to reverse our ambulance bay or other areas that we have stood up in response to the COVID crisis. Our peri-op area is very busy and working on a gradual type of ramp up plan to increase the surgeries, looking at certainly the priorities, the first priorities, urgent and emergent, and areas in which patients have been patiently waiting in order to receive their surgery and care with the suspension of elective surgery. So those are well underway. Many of the precautions that we put in place, we will be continuing, again, to ensure safety for our employees and our patients, but for the community as well. So we have a restricted visitor management system in place, restriction of various entrances that we will continue. We implemented a temperature, kind of a thermal scanning at all of our entrances, and universal masking. We will continue to do that. We have been readying our organization with 6 feet distancing to support the social distancing, which we know is working in our waiting areas, in our break rooms, and on our elevators, and to provide visual cues to our staff as well as patients that are coming into the organization. We have increased our disinfection and cleaning protocols, which we will continue to do throughout the organization. And we will continue in some cases for those who can continue to work from home to be able to do that. I'm going to turn it over to Dr. Casey, and he's going to talk about some of our resurgence plans in ambulatory and for testing.
So I would just add to Dr. Richard's comments. I think in spite of what you may hear, this is part of our new reality moving forward, is being able to take care of COVID patients. There's no such thing as COVID hospitals and non-COVID hospitals. In spite of some systems claim they're able to do that, it really is, everyone has to have the ability to take care of COVID patients. And I think just as we are uniquely prepared to care for this surge that you've heard about, I think we're also uniquely prepared to continue to be able to take care of routine preventative care in addition to COVID patients as we see them. So on the ambulatory front, we are, as an initial phase, opening some additional RUMG clinics with expanded hours moving forward. But as I referenced earlier, we're really also leaning on our virtual care platform. We've heard loud and clear from patients that virtual care is more convenient in many circumstances, and a better value from their perspective. So we certainly want to be able to continue to offer that. And I think, again, uniquely able to do that. I should mention, as we expand clinics, we've also had extraordinary patient experience throughout this entire period. So we have actually seen our patient experience scores go up through all of this care, which is really unprecedented and something about which we're proud. In terms of testing, Dr. Lin talked a little bit about the antibody testing that we have rolled out for employees. We want to continue to be able to make that available for employees and roll it out to patients as well, as we continue to study the meaning and better understand exactly how to interpret those results and what that may mean if it confers immunity for future exposure to coronavirus. So with that, I think we'll wrap it up and turn it over for questions. Thank you.
All right. So one question, I think, for Dr. Lin, would a vaccine be administered to children if one were available?
Yes, I would say that if a vaccine is available, there's so much that needs to be known about which target populations are most important and which populations would respond with immunity. But I would imagine that this would be offered to the entire population and not just a subset.
Just a point of clarification about testing for COVID-19. Are physicians and nurses tested regularly?
So this is Mike Lin again. So testing of all of our employees, staff, and students is very regimented, and it actually it's available for everybody. So we are testing people who have symptoms of COVID-19. There's a list that we adhere to from the CDC, and it's very important from the standpoint of our healthcare worker safety to be able to identify those workers who are symptomatic and require testing and to be off of work if positive.
Another question, has Rush seen any signs or cases of possible reinfection of the virus?
This is Mike again. So there's been some talk in the news about reinfection, and we've looked at our cases too. Some of the patients who have had symptoms have gotten better and then have had symptoms again. This is still an emerging science. We don't think that the cases that we've seen have actually represented reinfection. This actually speaks to some of the limitation of our testing, which is that the PCR that we use that detects the nucleic acid of COVID-19 virus, that nucleic acid actually can persist for quite a while, sometimes for weeks, even though the live virus is gone. And so in some cases, we are having patients who come back with additional symptoms who may test positive again with that nucleic acid testing that in fact have something else, and the nucleic acid is just hanging around. So I think there's a lot in the scientific community about studying this more, but at this point, we don't think that there's significant reinfection happening.
So this person presumably is an employer with locations in several states, and they follow the CDC guidelines of 7 days for quarantine. Many local health departments are requiring 14 days. This person is wondering if there shouldn't be a national enforcement of CDC guidelines.
This is Mike again. So I think that the 14 days comes from the incubation period between exposure and developing symptoms. So I think if the intent is to make sure that someone who's been exposed can stay away from work before going back and potentially being infectious, I think 14 days is a reasonable approach, and harmonizing that across the nation, I think, is wise.
I want to. This is Omar. I'd like to add to that for a moment. You know, the question specifically was about enforcing a national standard, and this is a unique time in the country. We live in an era where, you know, if you go back 10 or 15 years ago, if there was a disease, the CDC would come out with a recommendation. It was without question followed. We live in a world where social media dominates a lot of the way people get their news. Anecdotal information from other countries without validated sources scared a large number of people. So there were a lot of rumors that had to be dealt with around this time. And there was a lot of, I would say, distrust of the healthcare community, not just in the United States, but certainly across the world. What were the recommendations coming? Whole countries are being attacked for potentially the way they handled this. So it's an important question. Should there be a national enforcement of a standard? The reality is this is such an evolving situation right now, and we learn more about this virus literally every day, that when recommendations change, it unfortunately creates more distrust in the system than it does a sense of calm. And I think what we have to get to as a country is back to trusting the science behind it and the recommendations of the CDC. So I very much like your question and your point. But we live in a world where Dr. Fauci, one of the most experienced infectious disease doctors in the world, is questioned by 45% of Americans is his value in one survey. So it would be almost impossible to enforce a single national standard today. It's political.
And here's an easy question that I can answer. Will these slides be available for printing? And can we forward the broadcast to friends unable to participate today? The answer is yes to both. And we will make sure that we make it available as soon as we possibly can. And one final question that I think we can probably squeak in is any insight into when a widely available antibody test will be available?
This is Mike again. So it's really hard to predict the future. I think there's so many tests out there now. And I think once we get the science behind which tests work, I think it makes sense to test more widely. But at this time, we're taking a cautious approach that's science driven. I think that's important for all of us to take as well while we're navigating all this.
Yeah, I'll add there because this is such an important question for many people that have large companies or employees. We hear every day on the news that the key to reopening America and reopening the world is testing. What we don't hear on the news, but we're starting to see more and more stories about, is we have many tests out, but we don't have the validation numbers clearly understood. What does a positive test mean? What does a negative antibody test mean? The worst thing that can happen is you have a positive antibody test and a person would think they're essentially immune from getting the disease, and then they go and get it because the test was not accurate. So when Dr. Lin is really talking about understanding the science, historically, no test could ever be available in the market without this is what this percentage of positive means. This is what this percentage of negative means. Because of the rapidity and the drive to get testing across the world is flooded with tests without validation. And so what you're seeing now is each institution doing this under the guise of research. So we're doing antibody testings of our employees under research with the knowledge that as we track them over time, we'll have a better understanding of what that positive or negative test meant. So antibody testing is going to be a very important part of our future when the science of it is perfected and we understand what the results mean. And that's actively happening. It's not a doom and gloom statement. There's optimism around antibody testing in the future, but there's some work to be done right now about developing the algorithms of if you have, when does an antibody test become positive? What if you're within this window? What does that mean? Can you work? And all of that science is being worked out and those algorithms are being developed. I would say this, to say that we appreciate your time and your support of the institution would be an understatement. This is an unprecedented time of stress for healthcare in America and an inflection point for us in the future to really look back and say, how do we get better at a country of providing healthcare to our community, to our city, to our state, and to our country and world? And I think that right now, all I would like to say is thank you for your ongoing support. Thank you for your countless notes, as many of you have sent, and your willingness to even listen to us. I think we are truly all in this together. If ever more now than ever before, we need to work as a collective society to understand and help one another to get through this. This won't be done in 2 weeks. There will not be a moment where we just wake up and realize this is over. This is a marathon and not a sprint. And it will be much easier as we all work together. And so thank you for working with us as we do this together.
Thank you for joining us, and that concludes our session.